Hey there, it's time for another episode of Community Paramedic. I feel like Community Paramedic Story Time. Alright, folks, today we are jumping into Chapter 14, which focuses on the plan of care for your patients. So this is a little bit different. We haven't really dove much into this type of thing when we're talking about our usual 911 care. Our plan of care is a tool that helps keep all healthcare providers on the same page. It establishes a course of action, defines the priorities of care, and most importantly, it helps improve the patient's overall health. For us here in Western North Carolina, where patients may see providers across multiple counties, having that consistency is key, that nothing gets dropped. The plan of care always centers on three main things. That's going to be patient education, disease or injury management, and referrals to the right services. So think about how this applies here in our region. A patient maybe down the mountain in Polk County may not have access to specialists. A strong plan of care may make sure that they still get connected to the resources that they desperately need. Our integrated care is the foundation of a successful plan. Instead of different providers creating separate plans with everyone works together on one shared document. So that way everything is in one place. It ensures care is delivered effectively, efficiently, and consistently. Locally, this prevents a patient in Hendersonville from receiving a fragmented plan from multiple providers. The plan of care outlines the key elements needed to improve a patient's health. That includes clinical assessments, treatments, food plans, exercise therapy, patient education, as well as other activities. For community paramedics, this plan becomes our guide when we visit a patient in their home. The plan of care outlines all the major components that guide patient health or for the patient's health improvement. First, it includes clinical assessments, treatments, as well as procedures. These are the medical foundations, checking vital signs, performing wound care, giving treatments, and ensuring procedures are followed correctly. Second, it may involve food plans. Nutrition is often overlooked, but it plays a major role in recovery as well as prevention. For example, diabetic patients in Polk, Henderson, Buncombe counties benefit when their plan includes clear instructions about meals and snacks they can realistically prepare in their homes and what they have access to. Third, activity and exercise therapy are included. Movement is essential to both physical and mental health. That might be something as simple as walking to the mailbox daily, using stretching exercises to maintain mobility. In rural Western North Carolina, where many older adults live independently, activity goals keep people safe and functional at home. Fourth, patient education. That's a cornerstone of every plan. Education empowers our patients to take control of their own health. For instance, teaching a COPD patient about just how to properly use their inhaler can prevent avoidable emergency calls, or explaining to them what their multiple medications are and why it's so vital that they do take them, especially their water pills for our congestive heart failure patients. Finally, the plan of care includes any other activities necessary to improve health. This could range from scheduling follow-up appointments or connecting patients with local outreach services here in Western North Carolina. That may mean linking someone to a free blood pressure clinic in Hendersonville, or making sure they know about transportation services through their local community agencies. Together, these elements make the plan of care more than just a document. It becomes a roadmap for both the provider and the patient, ensuring consistent as well as comprehensive care. The plan of care is like a blueprint. So think of it as a blueprint. It is your blueprint for you as a community paramedic to follow. It gives you direction for implementation and a framework for evaluation of the patient's response to the designated actions that you are providing. Expected outcomes are the benchmarks of the plan of care. These are the specific objectives written into the plan that tell us when a goal has been achieved. Also, outcomes guide both patient activity and provider action. They also serve as criteria to evaluate the effectiveness of the plan. Key takeaways and testables here: outcomes must be specific. They have to be realistic and measurable. You have to put a measurable on here. Outcomes direct both what the patient should be doing and what the care team should be doing. They are used to evaluate the effectiveness, so you should be able to tell, did the plan work? Yes or no. An example might be a COPD patient in our area. An expected outcome might be maintain oxygen saturation above 92 on room air for 2 consecutive weeks. That's measurable, it's realistic, and it's tied directly to the patient's health. Plans of care always include both short-term goals, small little goals, and then our long-term goals of what we hope they get to at the end. Our short-term goals are things that can be achieved quickly, often within a week. They're little benchmarks that lead up to the long-term goal. The long-term goals take weeks or months and are usually focused on chronic conditions as well as prevention. So short-term, quick wins, something they can achieve. We want them to feel successful and have those wins, such as medication compliance or hydration over the next 48 weeks. Actually sit down with them with their water bottle and talk about how key it is and how much they do need to be ingesting water-wise per day. Long-term prevention, education, and mastery of self-management, these are especially important in chronic diseases. So those long-term preventions our long-term goals are going to be the prevention and education and that self-management. That is what we're trying to get them to in the end, by the end of this program. Your good old IBSC exam is going to test you in recognizing which type of goal is going to fit a scenario. For new diabetics in our area, a short-term goal may be a patient will check their blood glucose 3 times daily this week, and then a long-term goal might be a patient will maintain A1C below 7% within 3 months. There are other types of goals as well, patient-centered goals, which reflect expected behavioral and responses resulting from interventions. That might be drinking the glass of water, so 8 ounces of water 3 times a day. There's an observable goal, which allows the community paramedic to observe and record change that is taking place. Observable changes may relate to knowledge, behavior, as well as sociology, psychology. Example, the patient will increase ambulation by 5 additional steps each day. So that is a definite measurable and it's tangible as well. There are singular goals. These provide an opportunity for more precise evaluation in response to an intervention. Singularity allows the community paramedic to determine whether specific expected outcomes have been achieved and assist in determining whether modifications in the plan of care are needed. An example would be the patient's blood pressure will be less than 120/80 by November 20th. Incredibly specific, and they have a deadline. People work good on deadlines, so assign your patients deadlines. There are measurable factors. These include goals and expected outcomes that provide a standard against which to measure actual outcomes. Measurable terms allow the community paramedic to objectively quantify changes in the patient's status. Terms that specifically describe quality, quantity, frequency, and weight allow evaluation of the expected outcomes and determination of whether they have been achieved. An example would be blood glucose will remain under 115 with our daily checks. There's time-limited factors. These indicate when the expected response should occur, assisting the community paramedic and the patient in determining whether timely progress is being made and expected outcomes have been achieved and reached. On the predetermined date of evaluation, the community paramedic then decides whether the expected outcome was achieved or whether a future evaluation date needs to be set because the expected outcome was not met. If it was not met, try to build them up for success with maybe a more achievable goal for them to meet. Maybe we shot too high with that first goal, so we want to give them the small wins. The plan of care can look different depending on the setting. Some are chart-based, others are narrative. Many are now electronic through systems like Epic or American Data. So our format doesn't matter as much as the clarity and accessibility. So as long as we can read it and it's accessible. Our test does want you to know that documentation must be consistent. It has to be shareable and adaptable. A standardized plan of care helps ensure continuity across all providers. In Western North Carolina, some hospitals use Epic, but small clinics may still use paper charts. Some small hospital or agencies do as well. Community paramedics often act as the bridge between these systems. The plan is always built around the patient's needs. Typically, it's crafted by the primary care physician or the medical director. So we don't craft that plan. We do not build that plan. It is built by the primary care physician or medical directors. Sometimes we may have a nurse practitioner or even a physician involved as well, or a physician assistant, The plan is always individualized. It doesn't matter if the patient is post-hospital or just entering community paramedicine, everyone needs a plan. Community paramedics, once again, don't usually write the plan, but we do implement it with them. We may also tweak it with them. Many patients in rural areas only see their NP every few months, so having a well-crafted plan ensures paramedics know exactly what's expected between those visits. Some patients are referred into community paramedicine directly from the hospital. Discharge planning outlines the patient's continuing needs. So good discharge plans include education, safe medication use, food plans, rehab activities, hygiene, and referrals. These plans should prepare the patient to maintain independence at home. A CHF patient discharged from Mission Hospital in Asheville may have referrals to a dietitian, home health, and a local exercise program. Without a discharge plan, those referrals may never happen. The discharge planner is usually a nurse or a social worker. The primary care physician signs off and prescribes medication. Discharge planning is not just hospital-based. It must follow through into the home, and that's where we step in. The physician is ultimately responsible for approving the plan. Your IBSE exam is going to test on roles, so who coordinates what, who signs, and then who actually implements. These are testables that you will see. The huddle is where the care plans get updated. So there are regular team meetings, usually bi-weekly or monthly, that occur. So the huddle promotes collaboration, ensures everyone is up to date and in the loop, and identifies those barriers that your patients may be running into. Community paramedics bring frontline assessment data to the table. You were there, you were seeing the patient, seeing how they are struggling or what they are achieving, or maybe it's too obtainable of a goal. So your job is to report back. This is a dynamic process. Care plans must change with the patient. In Western North Carolina, these huddles are often held virtually because of our distance. So that way we can connect providers across multiple counties when needed. During the huddle, paramedics report on patient progress. The medical director or physician can then modify the plan based on that feedback. The huddle allows for real-time updates to the plan. Care is adjusted before problems escalate. Your IBSE exam may test your understanding that the paramedic doesn't rewrite the plan, but provides the data that drives that change to happen. Implementation is about interventions, the specific actions taken to move the patient from their current state of health to the expected outcomes. Interventions can be medication, compliance, patient education, chronic disease management, or even referrals, always guided by protocols and standing orders. Your IBSE exam is going to test you on examples of interventions versus assessment. For a CHF patient, an intervention might include reinforcing daily weight checks and connecting them with low-salt food programs. Implementation means acting within your scope. Community paramedics must always follow the diagnostic treatment protocols of their program. We are familiar with protocols. We have to stick with our protocols. They define exactly what you're permitted to treat and what type of treatment you're allowed to provide. So your protocols are your legal boundaries. You cannot improvise outside of our protocols, even if you think it might actually help. So there will be tests within our testing chapters here in IBSE that test your ability to recognize when to follow protocols and when you need to escalate. In North Carolina, the NCOMS protocols clearly define what community paramedics can and cannot do in rural areas. The temptation may be there to do more because resources for them are limited, but you need to stick to your scope, and that protects both you as well as your patients. Standing orders are another tool for implementation. These are written by the medical director. They are patient and condition specific. They allow the paramedic to act immediately after assessing a patient and identifying a need without waiting for new approval. So standing orders give you the immediate authority to act, same thing that we have in the field. They're always tied to a specific diagnosis or condition. So know that standing orders come from the medical director and not us community paramedics in the field. To select an appropriate intervention, you rely on both protocols and standing orders. Together, they provide the framework for safe, consistent decision-making. You must be able to show that your intervention was supported by either a protocol or a standing order. So you need to ask yourself, what is your authority to act here? That could be a key takeaway. When selecting interventions, everything comes back to the goals and expected outcomes written in the plan. If an action doesn't move the patient closer to these outcomes, it probably does not belong in the plan and needs to be reassessed or reevaluated. Interventions are not random. They must align with established goals. Ask yourself, does the action move the patient towards the expected outcome? If not, reevaluate and get with your huddle and figure out what the next step needs to be. Types of interventions. The community paramedic determines the interventions to apply based on the goals and the expected outcomes of the plan of care that each patient has. There are 3 categories of interventions: physician-initiated, collaborative-initiated, and community paramedic-initiated. Know the difference between these 3 categories. Physician-initiated interventions are based on the patient's medical diagnosis and written directly into the plan. The community paramedic, nurses, or other providers then carry them out. The physician writes it, paramedic implements it. Collaborative interventions require the skills of multiple healthcare professionals. These are complex cases where no single provider has all the answers. So collaboration is key with our multi-morbidity. Those are our patients with our multiple conditions. So your testable example, stroke patient who also has dementia and diabetes. They require PT, OT, nursing, medication management, and CP follow-up. In Western North Carolina, where resources are spread across counties, collaboration often involves referrals across systems. So Mission Hospital, maybe Henderson County EMS, local home health, all working together. So a patient who had a recent stroke might require physical therapy, occupational therapy, and medication reconciliation. Each provider has a piece of the plan, but success depends on communication between all of them. Collaborative care equals multiple providers contributing towards one outcome for the best of the patient. Community paramedic-initiated interventions are those you determine are necessary to accomplish goals as long as they are within your scope of practice. These often involve patient education, monitoring, or connecting resources. So remember, it must fall within your program scope of practice. Examples may be checking medication compliance, reinforcing diet instructions, or connecting with outreach services. The Omaha system, we've mentioned this before, is a standardized research-based way to document patient care. It focuses on 3 parts: problems, interventions, and outcomes. The IBSC may directly ask, what are 3 components of the Omaha system? It is all about consistency and clear communication between providers. In the Omaha system care, or the Omaha system care plan follows a logical format. There's an introduction, a diagnosis, defining characteristics, and expected outcomes. So you must know how a plan of care is structured. Expected outcomes always are tied back to the diagnosis and characteristics. The plan also includes goals, interventions, patient-family involvement, time frames, and referrals. It is comprehensive, covering every piece of the key continuum. Don't forget that family caregiver involvement is also part of the Omaha model. Time frames must be realistic but also flexible. Referrals ensure continuity after graduation from the CP programs, which is our primary goal with all of our patients. To craft the plan, the physician reviews documentation, history, interviews, diagnosis, as well as existing plans before selecting a care plan. You cannot individualize a plan without first gathering complete data. So your IBSC may test the order. It's assess, review, then select your care plan. Once the physician selects a care plan, they identify expected outcomes and customize interventions. This individualization ensures the plan fits the patient, not just the textbook. So your customization is very essential. Standard interventions must be adapted to your patient needs. So here we go. Let's do a little case study. So Sharon, she's a 55-year-old woman who was hospitalized with terminal stage pancreatic cancer. So step 1, We're going to review the documentation. We have Sharon. She's 55 years old and she's single. Her diagnosis is stage 4 pancreatic cancer. She's receiving 5 milligrams of morphine sulfate every 4 hours, oxygen, and Lasix for reduction of fluid retention. Step 2 is then going to be reviewing the patient history. Sharon developed pancreatic cancer 3 years ago and experienced a reoccurrence 6 months ago. She's just completed chemotherapy drug treatment. She's developed fluid retention in her lungs that requires repetitive training. The priority goal of care is to keep her comfortable. Then we go to step 3. Step 3 is patient interview and assessment. The interview and assessment reveal that Sharon has diminished breath sounds in the lung bases, shallow respirations of 24 breaths a minute, and crackles or rails in both lungs. She's alert and oriented and able to move all extremities. She complains of exhaustion as well as generalized pain. Step 4 is reviewing the patient diagnosis, and then step 5 is reviewing the existing care plans. Care will be provided for pancreatic cancer and immobility, and the patient will receive hospice care. The last step, step 6, a selection of care plans. So with our stage 4 pancreatic cancer, the patient may experience ineffective breathing patterns, pains, grieving, and the risk for infection, as well as constipation due to pain meds. Not all problems can be solved at once. Sharon's plan focused specifically on constipation, maybe. By narrowing the focus, the care team could address one priority effectively. So our plans must be prioritized. What is the biggest priority? Critical thinking comes into play. And being street medics, that's definitely a value for you. You can't tackle everything at once. So see what you can do the greatest good with the time that you have and with what we have with our patients. The physician then individualizes Sharon's risk, outcomes, and interventions. The plan was modified to meet her unique needs rather than just applying a generic protocol. Step 7 comes next, individualization of what our signs and symptoms are, what's our biggest issue with our patients. So we have a risk of constipation, we have individualized diminished defecation, lack of mobility, lack of privacy, increased time spent in the semi-Fowler's position, and a reluctance to use a bedpan. We then have muscle weakness, abdominal muscle weakness resulting from her decreased mobility. We have decreased GI motility due to decreased food and fluid intake, decreased activity, and increased anxiety. Step 8 would be our expected outcomes. The plan of care, it identifies the expected outcomes for the patients if the care plan is followed. Our outcomes will be individualized. Our patient will not experience constipation as evidenced by the following. They will have a passage of soft form stool at least every other day. There will be an absence of abdominal pain and distension, no feeling of fullness or pressure. They will have no straining during defecation. There will be an ability to maintain a bowel routine in optimal comfort. Step 9 would be individualization of actions. The author modifies the standard interventions to meet the needs of the patient and facilitates the expected outcomes. So we're going to assess Sharon every visit for signs and symptoms of constipation. Watch for pain, distension, feeling of fullness, pressure, straining, absence of bowel movements for 3 or more days. We're going to listen for bowel sounds. We're going to remain alert for any decrease or change within these sounds. And to prevent constipation, we're going to encourage them to go anytime they feel the urge. Position appropriately with the use of bedpan, give them privacy, maybe offer music for relaxation, encourage intake of high fiber foods, develop a plan for increased fluid take, recommend warm liquids in the morning to stimulate our squeezing and squishing peristalsis, monitor analgesic use, but also ensure that the pain management is kept up with. Maybe request milk of magnesia or other laxatives as needed, and then report signs and symptoms of change to the appropriate medical direction. It's a lot. For Sharon, the community paramedic's role was to perform frequent assessments at home and collaborate with her family and other providers. So some key takeaways and testables. IBSE loves to test. What is the CP's role in the Omaha plan? I would know it. The answer is going to be implement, assess, report, and collaborate. Remember, we don't write the plans. We just carry it out and communicate the results. Another example here is James, who's a 58-year-old recovering from a heart attack that led to a cardiac arrest. His physician created a patient-centered plan tailored to his needs. Every patient, no matter how acute or chronic, should leave with a plan. To implement James's plan, the community paramedic conducted frequent home assessments and connected him to outreach services. So implementation equals assessments plus interventions plus referrals. Our outreach is testable. We need to be able to connect patients to community resources. Last slide. Woohoo! The paramedic also watched for subtle changes in vital signs, eating, activity, and sleep. These small details can reveal major issues like depression or early deterioration. All findings were shared during the huddle to adjust the care for James. So early detection and small changes is a hallmark of community paramedicine. So once more, IBSE loves these small signs, subtle sign questions. Can you catch the quiet warning before it becomes a crisis? The goal is to not call 911 and to not tie up a bed. So as we wrap up this presentation on the plan of care, I want to emphasize a few key points here. First, remember that the plan of care is more than just paperwork. It's a roadmap that ensures consistency, safety, and quality of care across the entire healthcare team. For us as community paramedics, it is the blueprint that directs our actions and helps us evaluate whether our interventions are truly making a difference. Second, outcomes and goals are the heartbeat of the plan. They must be specific and measurable. They must be patient-centered as well as time-limited. Give them a deadline. On exams like the IBSE, you'll often see scenarios that test your ability to recognize whether a goal is written correctly or whether an intervention is moving the patient towards those outcomes. Third, implementation relies on protocols and standing orders. These are our legal and professional guardrails. We should be familiar with them. Finally, never forget the Omaha system. It gives us a standardized way to define problems, choose interventions, and measure outcomes. For test prep, you should always be able to name those three components and explain how they fit into a plan of care. So here in Western North Carolina, this is in theory, we work in rural counties where patients often don't have easy access to hospitals, specialists, and the plan of care is what keeps them safe at home. It reduces those unnecessary ER visits and helps us build bridges between patients and the resources they need. So as you study this material, think beyond just the test questions. Think about how these concepts play out in your communities or the small towns tucked into the Blue Ridge Mountains. The plan of care is where the science of medicine meets the art of patient-centered care. And that is what makes community paramedicine both challenging and rewarding. That's all I got, guys. As always, stay safe. If you need anything, please don't hesitate to reach out.